I'm Seyda Yilmaz Ozal, a research assistant at Gazi University in Turkey. I'm a physical therapist. I will get my PhD soon, I hope in next month. I am happy to be in this excellent organization. I would like to thank the organization team for their kind invitation, and especially Linda Larkin for her guidance during the process. Now I will tell you the cross-cultural adaptation of self-report outcome measures for multinational studies in healthcare. With this presentation, I will try to give you information about self-reported outcome measurements and their adaptation process. First, I would like to talk about contents of these tools and their significance in healthcare. Later, I will explain the importance of correct adaptation so that more people can use these tools. Finally, I will explain the adaptation process. In clinics, we try to get as much information about the patient as possible to solve the problem. We need the clinical measurements for examination, diagnosis, making a clinical decision, choosing the best treatment method, checking the results, comparing the results with other patients, and determining the priority of the various treatment methods. We need some measurements such as vital signs, laboratory tests, performance tests, and imaging methods. These give us precious objective information about the patients, of course. However, we need to understand the patient's perception, experience, and feelings about the situation to interpret all these measurements correctly. At this point, our best helpers are the disease, symptom, function, or population-specific scales, questionnaires, or indexes. Thanks to these helper tools, we can imagine the situation of patients and empathize with them better. We may call them patient-reported outcome measures, self-reported outcome measures, or health-related quality of life questionnaires. Although they mean close to each other, they have some differences, nuances. Quality of life questionnaires are inclusive skills that investigate disease-related impacts, consequences of the disease. We may also call them patient-reported outcome measures or self-reported outcome measures. When a scale with a single or limited focus, such as a symptom, function, or emotion, we prefer to call it patient-reported outcome measure, because here we assess a more limited portion of the impact, not whole quality of life. Again, it would be more appropriate to call skills self-reported outcome measures for a healthy but specific group, such as athletes, women, pregnant children, elderly, etc. They are similar but not the same. We must choose in direction of our intent. I choose the self-reported outcome measures as it contains the others. Then why we use the self-reported outcome measures? Sorry, did you say anything? I heard a sound. Okay, I'm going. Why we use self-reported outcome measures? Because self-reported outcome measures put patients at the heart of the research and care. They give us precious information about the symptoms, function, emotional expressions, satisfaction with care, adherence with therapy, perceived value of the healing, and health-related quality of life. They allow us to have detailed information about the patient in a short time. They improve patient-physician communication. We can check health status quickly. They are cheap, easy to understand and apply. The most important one is this point. They reflect the sincere reports, real sensation and feelings of a patient. So it will be very advantageous to use these tools in clinics and academic studies. Are they really useful? In an outcome measurement development process, a developer should investigate whether the questionnaire has some psychometric properties. The validity and reliability level of an self-reported outcome measure must be calculated to be determined as an outcome measure. Therefore, a tool that meets these requirements, yes, is useful. They generally correlate with other symptoms of the disease. There are many studies in the literature that support these conclusions. Why do we need to make self-reported outcome measures understandable and applicable to more people? Because more people should benefit from a valid and reliable and practical tool in healthcare. People all over the world struggle with similar health problems. However, access to healthcare services is not the same level for everyone. The spread of healthcare methods is essential for universal health. It's possible with the broader medical screening and information sharing. Thus, evaluation criteria should be as standardized as possible. To make procedures more standardized, we need standardized outcome measures. Yes, we are different. Yes, we are independent individuals, but in fact, we are completely dependent on each other. The individual health depends on public health. We realize this fact much better with the COVID-19 pandemic disease, as you know. To develop the healthcare services, we have to focus on broader perspective. We need the global research studies, multinational studies beyond the local ones. Why do we need to expand the usage areas of self-reported outcome measures in healthcare? When we reply this question, we may say that they enhance multinational and epidemiological studies, improve standardized assessment and treatment outcomes, presenting and comparing the results and subsequent diseases or treatments. They maintain collecting larger data and outputs. We need larger surveillance and research outputs. What should we do? Translate or adapt? Or translate and adapt? We are different from each other, like the various colorful flowers in this beautiful garden. We have various behaviors, lifestyles, habits, cultures, opportunities, and conditions. The various features came from our roots are also reflected in our language. Our choice of words, tone of speech, body language, idioms, proverbs are shaped according to our identity. Therefore, translation is not always sufficient. We have to culturally adapt. Meaning of a word is not the same for everyone. When we question an activity, we must consider what it means to the person. For example, gardening has different meanings in each geographic region. It is even different for those living in rural and urban settlements in same region. Here we see a question designed to assess a person's eating skills. Do you have difficulty eating with a fork? A perfect expression for a society that uses a fork as a means of eating. And the same for the population using other eating utensils, chopsticks, or etc., or another thing. No, we should change our expressions. We should adapt these expressions. Another concept that differs is praying. There are various prayer positions. Everyone repeats these positions with various frequencies and or durations, and they may be associated with various muscle and joint pains, such as low back pain, knee pain, and ankle pain. Sporting or recreational activities are another issues. Here we see an example from the ability of shoulder and hand questionnaire. Engaging in sports such as golf, wrestling, American football, hockey, and frisbee, and leisure activities such as playing cards and knitting also show social differences. Therefore, it would not be appropriate to ask someone who does not exhibit these activity. Instead, another activity that requires similar movement or effort may be questioned. Parallel to increase in multinational and multicultural research projects, the need to adapt hosted use measures for use outside the source language has also increased rapidly. In addition, some countries have multiple official languages. There are culturally different countries that speak various versions of the same language. Even in unilingual countries, researchers should consider immigrants, especially if their exclusion may lead to a systematic bias of quality of life studies in healthcare. So it's crucial adapting valid and reliable outcome measures to different cultures to provide mutual outputs with multinational studies. So, when should we translate or adapt? If we use it in the same population, no need for any translation or adaptation. If there are established immigrants, they can understand the language, but they would have a different culture, so adaptation will be sufficient. The same language usage in a different country again requires only adaptation. But in a different country or for new immigrants, we should translate and adapt the two. So far, I have tried to explain why and when we need to adapt. Now let's talk about how can we adapt the questionnaire. Our primary aim is to maximize the attainment of semantic, idiomatic, experiential, and conceptual equivalence between the source and target questionnaires. To date, many translation methods have been tried and explained in health studies. However, the most accepted method is a multi-step translation and adaptation method described by Beaton et al. We can see the steps and workflows in this graphic. The first stage in adaptation is the forward translation. Many recommend that at least 2 forward translations. The 2 translators should have different profiles or backgrounds. One of the translators should be aware of the concepts being examined in the questionnaire. It is preferred that other must be blind. Each translator writes a report. The rationale for selection of the word is also summarized in the written report. Additional comments are made to highlight challenging phrases, ambiguities, or idioms. The second stage is synthesis of the translations. Translators and observers lead this process. They check the translation reports and negotiate with each of the issues. By the code decisions, they produce a new translation version. They also document the synthesis process of how the issues were solved. Then blind translators translate the questionnaire back into the original language to make sure that the translated version is reflecting the same item content as the original version. This step often reveals ambiguous expressions in translations. It provides control of the decisions made in the previous steps. At least a bilingual translator should compare the translated and original versions. At fourth stage, the expert committee meets and check the whole process. The expert committee consists of methodologists, health professionals, language professionals, translators. They analyze all translation versions and reports. They investigate the semantic, idiomatic, experiential, and conceptual equivalence between the source and target versions, and make clinical decisions to produce a pre-final version of the questionnaire for file testing. Here, semantic equivalence is about meaning and grammar. Idiomatic equivalence search the collocations of words, phrases, or idioms. Experiential equivalence is relevant to habits, behaviors, experiences, and cultural differences. Conceptual equivalence is also shaped by emics and ethics. In the fifth stage, the new tool should be tested in a small group. The comprehensibility of each item should be questioned separately. Comments and suggestions should be recorded. Checking the pilot study results in this stage, comments and suggestions are considered, making changes if necessary, determining and reporting the final version. Is the work finished? No. These steps show that we have a successful translation and adaptation product, but they don't prove that the new version of the scale is valid and reliable. The psychometric properties of the new version, such as validity and reliability, should be evaluated again. So when we summarize, we can use self-reported outcome measures to strengthen clinical assessments and understand the patient's feelings. With adaptation studies, we can expand the scope of existing self-reported outcome measures to make comprehensive studies involving wider audience and compare results in healthcare. The translation is not sufficient for health tools to be used in another language. A detailed cultural adaptation study should be carried out. The validity and reliability of the adapted instrument should be evaluated in the new target population. Now let's practice with a questionnaire. How did you feel when you listened me? I am worried about your answers, but I hope you at least found it bearable. Thank you for